Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
So, hi, I'm Nora Hanna. I'm the Chief Engagement Officer for Sun Health. And I'm going to give you a little bit of history about Sun Health because I know when I first heard about Sun Health, I was like, sounds kind of familiar, but I don't really know what they do. It's really a fascinating organization with a super rich history. It started in the 60s in Sun City. And what happened was, even though Del Webb did an amazing job building Sun City, there were a few things left out, one of which was access to acute care. You could not get an ambulance to come to Sun City and take you to downtown Phoenix or to Youngtown. It was too far. And the amazing part of the story to me is a group of concerned citizens got together and said, we need to fix this. And I have this idea of them sitting around a room saying, hey, let's build a hospital. And them going, yeah, let's do that, which to me just seems crazy, but they did it. And they went door to door, and we remember these old thermometers that we had. So keep in mind, this is in the 1960s. They're raising $9 million to build the hospital, which is just remarkable. So they built the Boswell Hospital. Walter Boswell donated the land. And of course, having roots in Sun City, there was a lot of real estate involved in the whole process. And they were so successful, then they built the Del Webb Hospital, and they were really on the vanguard of something we're going to talk about today, which is preventive health. Because 40 years ago, Sun Health founded the Alzheimer's Research Institute, which is on the Boswell campus. And really, that was on the vanguard of all this work that we're doing now to say, boy, all these, aging diseases that we're all feeling, we need to figure out how to head them off at the pass. And now that research center has become one of the best known in the world. They have the largest brain bank in the world. So they do remarkable research right here in almost our backyard, our neighbor's backyard, we'll call it, over at the Boswell Hospital in Peoria. A few other things about Sun Health. I represent, in addition to Sun Health, the Sun Health Foundation. We are the fundraising arm for the two Banner hospitals that are there, Boswell and Del Webb, as well as the Sun Health Research Institute, which is also part of Banner now. But we also raise money for a variety of other things, including community services and making sure the community at large has access to these healthcare resources that are available. And we also do scholarships, largely around healthcare. And we're embracing a new challenge to build the healthcare scholarships in the Southwest Valley. So Estrella Mountain and other institutions that educate healthcare workers will be a big part of who we'll be working with moving forward. So with that, I'm going to turn it over to our speaker today. I met Dr. Sadeghinia at an event for the Arizona Heart Association. Sun Health, as well as Abrazo, has been the lead sponsor of the West Valley Heart Walk. This year will be the third year we are having that walk. It will be on November 15th. I have learned so much about heart health in this process of being a chair of the Heart Walk last year, and ended up getting my cardiac calcium test and doing all these different things because I just didn't know, I didn't understand all the different elements of preventive health around your heart. And sure enough, colleague of my husband's who is a marathoner, just uber great great shape, just had a cardiac incident, and sure enough, went and got his cardiac calcium test, and I don't know, it was like 400 something. Is that possible? Anyway, it was shocking. And so you just don't know by your physique or anything like that what your cardiac health is, and particularly for women. And that's why, it's often called the silent killer. And it is really important that we all build our awareness here and learn more about how we can measure our cardiac health and take care of our cardiac health. So I'll tell you a little bit about Dr. Sadeghinia. She attended, I want to say Cornell. I mean, it's not on here the way I thought it would be. You went to Cornell for medical school and then went for Yale also. But the other thing I saw on here is that you spent 9 years in Yuma.
Yes.
Is that right? I want to talk to you about that because I know some cardiologists there. How shocking is that? And I imagine you probably saw some of the valley fever issues in Yuma, of all places. Anyway, she is with Biltmore Physicians, Biltmore Cardiac, Biltmore Cardiology, and also aligned with the Abrazo system. So we're very happy to have her here today to share more information with us.
Thank you. Can everybody hear me?
Yes.
Yes?
Oh, but we need to record it.
Oh, I have to.
Sorry. You have to use the microphone.
This is meant to be very casual, and I'm going to assume nobody knows nothing about the heart. How many of you guys know someone with heart disease? Raise your hand. Good, at least every table one. So you have to forgive me, I thought this is women and heart disease, but I'll try to include men as well. So let's start with that. Heart disease is the #1 leading cause of death in the United States. And so 1 out of every Americans die of heart disease every day, if not more. And so some of the questions you may ask yourself are, for example, at what age do I need to start worrying about heart disease? How can I prevent it? And what are the treatments available? These are the things I'm going to cover today. And also, last but not least, what are the symptoms? How do I know I have heart disease, and what do I need to worry about? Now, remember, heart does not look like. Can everybody hear me? What they present us on that. Yes.
No, but we need to record it.
Oh,
Yes.
I'm
sorry.
This is meant to be very casual, and I'm going to assume nobody knows nothing about the heart. How many of you guys know someone with heart disease? Raise your hand. What do I mean by that? At least every table one. So you have to forgive me, I thought this is women and heart disease, but I'll try to include men as well. So let's start with, heart disease is the #1 leading cause of death in the United States. And so 1 out of every Americans die of heart disease every day, if not more. And so some of the questions you may ask yourself are, for example, at what age do I need to start worrying about heart disease? I don't care if you don't. How can I prevent it? And what are the treatments available? These are the things I'm going to cover today. And also, last but not least, what are the symptoms? How do I know I have heart disease, and what do I need to worry about? Right. So now, as a structure, and I want to break it down because when people come and say, I have a family history of heart disease, to us cardiologists, I don't know what that means. What do you mean they have heart disease? So that's why I'm breaking it down for you. Now, this is the structure of the heart. Here is kind of looking at it more anatomically. As you can see, these are your atriums. This is aorta. That's how the blood exits the heart, goes to the rest of the body. And these are the valves or the leaflets connecting one chamber to other chambers. If I was to cut this down cross-sectional, this is what you're looking at. All right? So here's the left side, we call it mitral valve. If it's right side, tricuspid valve, aortic valve. I'm just bringing it up, not that I want you to remember any of this, but at least you hear the words aortic valve, mitral valve, tricuspid valve. These are, think of it as if somebody has a leaky valve or a tight valve, That's a structural problem. All right? Okay. And of course, there is the muscles itself. Remember, it's a pure muscle. It's a sac of muscle. It's a pump. All it does, it makes the blood go round and around in circulation. Here's kind of more anatomically what it really looks like, just to see how the leaflets work, how they're in shape together. So let's start with electricity of the heart. Just like the building has electrical conduction, here are the electrical wiring of the heart. And the way we look at the electrical activity is through what we do EKG, which I'm sure some of you, if not all of you, have had an EKG at one point. So when your doctor does an EKG, they're looking at an electrical. They're not looking at the structure. They're not looking at the plumbing. They're looking at the electrical activity of the heart. Here's what it looks like, an electrical conduction. Here's another. Now, so what are some of the problems with electrical? So if the electrical activity, there's a problem with it, and the problem is from upper chambers. Remember, the upper chamber is called atrium. An example of it would be atrial fibrillation, atrial flutter, SVT, premature beat. Some of you may or may not have heard of those terms or not, but these are some of the electrical problem of the heart. And depending on where the electrical disease comes from, we call it that. For example, if the electrical problem comes from the atrium, hence we call it atrial fibrillation, atrial flutter, atrial whatever it comes. So I kind of want you to understand this is an electrical issue of the heart. This is showing you what is an AFib, and I bring this because it's one of the most common electrical problem of the heart. And so this is a normal beat, boom, 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 boom. Atrial fibrillation is all over the place. So it goes boom, 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 boom. So the heart loses its electrical conduction across the heart. So this is some of the examples of electrical activity, and AFib is the most common electrical abnormality of the heart, and we can get to it later more. Atrial fibrillation can make your heart go very, very slow and people pass out. Normal heart rate, we want it to be 50 to 80s. Or it can go really, really fast, 250 beats per minute. Either way, when the people can't tolerate it, they can pass out and they can have different variety of symptoms like dizziness, lightheadedness, short of breath, feeling tired without doing anything. Now, all that was just electrical problem. All right, let's move on. Here again, I'm showing you the basic of where we start at the beginning, the atrium, 2 chambers up, 2 chambers down, and the structure. Now, we talked about the electricity, we talked about structure, let's get to the plumbing. So, heart is a muscle, and just like any other muscle, it needs blood supply. So these vessels are the plumbing, the pipes that provide blood supply to the muscles of the heart. Whenever you have plaque buildup, it interferes with the flow of the blood. That's a plumbing problem, and hence we call it coronary artery disease. When you have more than 70% of the vessel blocked, the muscle is not getting the blood supply it needs, therefore that's what causes heart attack. So what is a heart attack? Heart attack is a plumbing problem when you have blockage at least minimum 70% or more blocked, and muscle is not getting adequate blood supply. You know, if you run too much, more than your calf muscle are using, you get cracked out, right? You're not getting enough blood flow. It's a concept of demand and supply. And so you get cramped up. That's nothing any different than the muscles of the heart. When the muscles are not getting adequate blood flow, then you get that chest pain, all right? Which I will discuss that in a second. So you notice when heart disease, how much it's divided? So when people say, my mom had heart disease, what did they have? I don't know. So I kind of want you to understand where I'm coming from when I discuss this with you. Now, plaque buildup, when I said number 1 cause of death in the United States, it's really coronary artery disease, all right? The plaque buildup doesn't happen overnight. It's decades and decades of what we call plaque buildup or atherosclerosis. When it builds up, so if somebody had their heart attack at age 70, it didn't build up a couple of years. That was started when they were in their 30s and 40s, all right? Because overall it builds up. So it takes that much time to build up. It's not over a week, month, or a year. What do we do about it? Basically, we take our patients to the cath lab. We put a deflated balloon. This is, look at your back of your hand. Look at how thin your vessels are. So imagine how thin this catheter is. It has a deflated balloon. We inflate the balloon and we expand the stent. Everything gets removed, stent stays there, and that's how we open up a vessel when somebody has a heart attack. This is where we usually do that. The patient is laying flat. Most of the times I hear them snore, but they're wide awake, they know what's going on with them. But you're very comfortably sedated. We go either through the groin or the wrist. We introduce a catheter, goes all the way inside your heart. We inject a dye, and the dye or the contrast, it flows all the way. Your heart is supposed to light up like Christmas tree. Whichever branch is not lighting up, that's how we know where the blockage is. And then we put the balloon and a stent, and that's how we open it up. If a patient has too many blockage or too extensive and they don't qualify for stent, those are the ones that go through coronary artery bypass graft, or for short we call it CABG. But this is basically the gist of coronary artery disease leading to the heart attack, all right? Now, what are the symptoms? The symptoms classically are chest discomfort where, now remember, this can be subjective. What I may call pain, another person may say, no, it's not pain, it's tightness. No, it's pressure. No, it's heaviness. It doesn't matter, but any kind of discomfort, pain, pressure, tightness, heaviness, in the chest. Predominantly if it precipitates with activity and it goes away with rest. That's a classic symptom that like they taught us in medical school means the patient has heart disease. But to be honest with you, those studies are at least 70 years old. They were done in nothing but a bunch of white men somewhere in Scandinavia. And when we did more tests where we included different races and women, that not everybody necessarily presents itself, especially with women. I remember when I was in medical school, one of my roommates' mom said, every time I get on my treadmill, my left ear feels heavy. That was it. I just feel heavy in my left. When I stop, that heaviness goes away. Well, thank God she had a very, very smart internal medicine doctor. Said, let me put you on a treadmill and see what happens. And of course, it showed it was abnormal. Believe it or not, next week she had a bypass surgery. Now, if you get chest discomfort, as long as it's less than 1 minute, pay attention, ladies and gentlemen, that's not heart. Heart doesn't come and tease you and walk away. So if you get a twinge, you're like, ooh, is that it? No. Usually so a couple of things. If I have two patients in ER, one is screaming of pain, the other one is quiet. Guess which one I worry about most? The quiet one. That's why heart disease is #1 killer, because it is mild, people ignore it, and sometimes it's silent. You can die in the middle of the sleep, which, by the way, I think it's the best way to go, but you didn't hear that from me. Also timing. If it's less than a minute, again, it's not your heart. If you can put your finger on it and say, my pain is right here. No, it's right here. No, it's here. If you can put your finger on it, that's not your heart. Because remember, the chest cavity, if this represents chest cavity, and this is the heart, there's no point of contact. So if you can put your finger and say, I have pain right here, or right here, If you can put your finger on it and it's focal, it's not your heart. If it's less than a minute, it's not your heart. Sometimes it's just shortness of breath, no chest discomfort, all right? So you don't have to have chest pain. It could be presenting symptom is shortness of breath or fatigue or tiredness. I have patients who say, I was able to go check my mailbox, no problem. Now, I just have to slow down. I don't get chest pain. I don't have any shortness of breath. I just know I'm not myself. I'm just tired, all right? Those are the symptoms that are we looking for. This, we talked about it. Sometimes pain can go only on the jaws or left arm, maybe, maybe not. It's not for you to decide, is this my heart? All right? It's for you to make sure you acknowledge. If you have any problem, go to your doctor or a cardiologist. Let us help you. All right? So this is by no means to make you a doctor to know everything about heart disease, but I'm just telling you the warning signs. Sometimes there are associated symptoms like dizziness, lightheadedness, God forbid you pass out. All those are the symptoms that is a telltale sign that you should take your signs seriously. And how do we diagnose coronary heart disease? In the hospital setting, we do blood tests. We can do EKGs, we do echo. Echocardiogram is to look at the structure and function of the heart. Exercise treadmill test is it's a screening test. I want you to think of the exercise stress test like a mammogram. What do I mean? Mammogram is to screen for breast cancer. But does that mean every time mammogram picks something, that means it's cancer? No, it's not until they do biopsy. The same thing with the exercise treadmill test. It's a screening test. Just because you don't pass the exercise, does that mean you have heart disease? No, but that's when we proceed. We're doing further testing, which is angiogram, or we do heart scan, which is what they were talking about as far as coronary calcium score. All right. Now, who gets heart disease or coronary artery disease? These are some of the risks that can cause heart disease, or when I say heart disease moving forward, I'm talking about coronary artery disease. We're talking about plumbing. So I just kind of want to, moving forward, when I say heart disease, I know I initially said they're differential, but right now, going forward, heart disease, I'm talking about plumbing. So these are the risks: poor diet, having high blood pressure, being overweight, lack of exercise, smoking, too much alcohol, diabetes, and cholesterol. These are what causes coronary artery disease, and we're going to go over one by one. For women in particular, what we found out that other things, this is just for women or females, things that increases your risk of coronary artery disease are premature menopause, gestational diabetes, hypertensive in pregnancy, preterm delivery, polycystic ovarian syndrome, any systematic inflammatory or autoimmune disorder like lupus, Jurgen syndrome, thyroid disease. These are also increases your risk. So with my female patients, I always, a number of pregnancies, was there any complication with your pregnancies? All those have been established that increases your risk of coronary artery disease, believe it or not. So, age. Of course, you don't, if I tell you a 90-year-old had a heart disease, any of you are surprised? No. What about if I tell you a 20-year-old had a heart attack? So age is a risk, all right? The older we get, the higher risk we have for having coronary artery disease. So age is a risk. Diabetes. If I check your blood sugar right now, that's what your blood sugar shows. It should be less than 100, your fasting blood sugar. Fasting, all right? Hemoglobin A1C, it's a blood test where it tells us how well the sugar was controlled over the last 3 months. Because a diabetic patient can come, not eating anything, doing great. I check their blood pressure and you think, hey, I have diabetes under control. But when we do A1C, if it's 10, 12, that means the diabetes is not well controlled. So diabetes is worse than cancer. All right, so this is a massive beast that any of you, if you have diabetes, you want to make sure this is under control. You can be on the best drugs in the world for your heart. If your diabetes is not controlled, the bets are off. So make no mistake about it, diabetes is extremely important. High cholesterol, a lot of patients come and say, well, my good cholesterol is high, so I was told it's okay, my bad cholesterol, because they cancel each other out. Well, this is not a tic-tac-toe game. One good one doesn't mean if your bad one is high, it's gonna be okay. No. So the total cholesterol, we want it to be less than 200. Triglyceride, this comes from carbohydrate and starches. I call them white food. White sugar, white rice, white potato, white flour, white tortilla. Triglyceride has to be less than 150. HDL is the good cholesterol. I want you to learn H for high. The higher, the better. This is the one that protects you. Estrogen keeps our HDL high. The only thing that, there's no drugs that can increase your HDL except weight loss and exercise. LDL is your bad cholesterol. The lower the better. You want this to be lower. Depending on age, this varies. So I don't want you to think 130 is if you have no risks, all right? But if you're diabetic, the goal is LDL no matter what age you have. And as you see, the building block of every plaque is a cholesterol plaque. Hypertension. What do these numbers mean anyway? Remember, our heart is a pump and it does two things. It has to contract and it has to relax. The only time we have no pressure is when we're dead. At all times, we have blood pressure. When the heart is squeezing, we call it systolic. That's the pressure upstairs. When the heart is relaxing, that's called diastolic or lower number. We want the blood pressures to be less than 130s on the upper and less than 80s, less than 90, the lower part. There's no such a thing, well, patient comes with blood pressure 150 over 80 or whatever, and they tell me, well, I was told this is normal for me. No. It doesn't matter what age you're on. I don't care what your size, height, sex is. Normal blood pressure has to be less than 140 over 90. And we talked about what those numbers represent. This is when the heart is contracting, systolic pressure. This is when the heart relaxing, diastolic pressure. Now, some people can have systolic hypertension. Some people can have diastolic hypertension. And some people have both systolic and diastolic hypertension. Which one is the worst? It doesn't matter. You have to control it. As long as you control it, it doesn't matter which one you have. Systolic hypertension, diastolic hypertension, or both. So you have to have those controlled. Usually when a patient comes to us and they want to know whether hypertension has caused any damage to the heart, I do an echocardiogram or ultrasound of the heart. What am I looking for? I look at the thickness of the heart on echo. If the heart has become thick, that means the blood pressure is not being well controlled. What am I talking about? If I go to the gym and I work on my bicep, what happens if I keep lifting heavier and heavier weight? Your muscle gets bigger, but that's a normal physiological response. If your blood pressure here is 120 over 80, the heart says, no problem, I do this for a living. But what if the blood pressure is 160, 180? Now the heart says, I have to squeeze harder to keep the blood going, move forward, right? Over time, this gets thicker too. The problem is, this is not normal physiology. You overworked your heart, and therefore it's pathologic. Think of it as a rubber band. If you stretch it too much, too fast, too hard, too often, what happens to the rubber band? It gets loose, it loses its elasticity. That's what happens to the muscle of the heart, and people can go into heart failure because the heart says, okay, I'm done, I can't do this anymore. So that's why hypertension is called silent killer. You don't have symptoms. It's not like catching a cold where you have runny nose, watery eyes, you know something is wrong. You can run a high blood pressure and you don't know unless you check, which is why even for our young audience, you don't have to worry about your high blood pressure. But if you know your parents have high blood pressure, you want to keep an eye on it. And that's also another reason I want to bring it up is if you have heart disease or something runs in the family, talk to your kids or grandkids. It's not about worrying them, it's about educating them that, oh, I know what runs in their family, because you have no idea how many times I see patients when I ask them, is there a family history? Like, I don't know, my parents don't talk to me about their health. You know, they don't want to worry me. It's not about worrying. Knowledge is power. You've got to educate your family. Smoking, whether you suck it, you chew it, you smoke it, you vape it, the best time to stop is now, all right? Why is nicotine or tobacco bad for you? It's a pro-inflammatory. It thins it encourages plaque buildup, and it allows the cholesterol to attach to the walls. So it's kind of like having your foot on gas pedal, speeding the process of coronary artery disease buildup. So that's why we do not. Now imagine if you have diabetes and you smoke. Holy cow. Obesity. 2/3 of America is overweight, obese, or morbidly obese. I want to tell you very quickly about obesity. The fat cells, we call it adipose cells. The fat cells don't just accumulate under the skin. It penetrates the organs. If it penetrates and infiltrates your kidneys are the organ that control your blood pressure. Hence, you get hypertension. When the fat infiltrates the liver, that's where the cholesterol is synthesized. Hence, you get high cholesterol. When it infiltrates your pancreas, that's where insulin is synthesized. Hence, you get diabetes. So with obesity comes diabetes, hypertension, cholesterol, and with that combo comes heart attack and stroke. So obesity is not a cosmetic concern. It's actually, American Medical Association had established that obesity is a disease, just like asthma, lupus, anything else. So obesity is a huge risk factor for heart disease, not to mention breast cancer and prostate cancer. Sedentary lifestyle. You know, nowadays we adopt a lifestyle where we're willing to drive 10 times in the parking lot looking for a place. Why? Because you don't want to walk. You know, so many times I see in different places, whether it's mall or airport, people wait in line to get an escalator, but hardly anybody wants to take the steps. Everything is drive-through. So American Heart Association decided to come up with a prescription because people have to be constantly instructed, which I think is really sad. We have to tell people about walk. You know, I remember one time I asked one of my patients, how often do you go for a walk? And he says, what's so nice about walking? 150 minutes of exercise per week is minimal. Now, what I expect of my 9-year-old is different than what I expect of my 19-year-old. If my 9-year-old says I go for a walk, bravo. But if my 19-year-old says I go for a walk, I smack them in the head. They should be doing more than 150 minutes. Now that 150 minutes has to be moderate intensity, meaning if you walk and you can have a full conversation, that's not moderate. Now this is age dependent. You know, if I have my 9-year-old with walker, with cane, I just want him to move. You know, movement is very good. So it has to be 150 minutes. You can divide it 30 minutes 5 times a week or 50 minutes 3 times a week, whatever suits your schedule. A lot of times people say, I don't have time. You make time. I don't care how busy you are number one priority. Nothing is more important than your health. Make time. Strength training is extremely important in especially elderly because it helps you with the balance to catch yourself. So don't underestimate strength training, weightlifting, just minimum to keep your bones and your muscles strong. That also counts toward the exercise. Family history. Now, family history. People come to me and said, I have a family history of heart disease. My mom had a heart attack at age 80. What we're looking for is if your mom or anybody female related had their heart attack before menopause, or your dad or grandfather had their heart attack stent bypass before age 50. So if somebody says my grandmother had a heart attack, I ask them what age. If they said, yeah, my grandma died at age 30, that's a risk. But if their their female family members had their, so age is very important in family history. Don't label yourself. If your mom, grandmother, sister, anybody had their heart disease after menopause, that's a lifestyle, not a bad gene. So that's what I'm driving at. If your father, grandfather, uncle had their heart disease before age 50, yes, that's remarkable. But if they had it after 50, that's a lifestyle. One step further that I take, I said, what did your father have that heart attack? Oh, well, he was a chain smoker. Well, there you go, right? Alcohol is good. Now, there was a study done at Denmark where they looked at 30,000 at the supermarket, the receipts. And what they found out is that people who buy beer, they're more likely also buy unhealthy stuff. People who drink wine or purchase wine also get healthy stuff. So it's not just the alcohol, it's really the lifestyle. Because the question was, which one is better? Wine, beer, hard liquor, blah, blah, blah. It's the lifestyle, it's not just the, what's a big deal about alcohol? They have polyphenol. There's 65 polyphenols. You can also find them in berries and fruits and vegetables. So alcohol is not the only source. Another source is fish oil, which is antioxidant. Weight loss is extremely important. I don't believe one size fits all. What may work for one person may not work for another person. So you have to find out about demand and supply, portion control, fast food, you have to get rid of it, no processed food, more vegetables, more salads, more fruits. I'm done. I actually have a clinic at 9, but I told my manager, to 10? Oh, thank God. All right, any questions? You don't get to ask questions.
I don't.
No, because I see you tomorrow. No, I'm just kidding. Tell me.
So is family history of cardiac disease more likely to affect plumbing or structure or electrical?
Family history of what?
Of having a heart disease, having a heart attack.
So you're going to talk about plumbing then?
I'm asking, does family history affect the plumbing, the electrical, or the structure more?
So as I mentioned, it depends what was running in the family history. Was it an electrical issue? Was it a plumbing issue? Was it a structural issue?
So there's a direct correlation, but what's plumbing in the family history affects your plumbing? Okay, thanks.
For example, atrial fibrillation doesn't run in the family. Okay, so just because somebody had atrial fibrillation family doesn't mean you get it. The point is you clarify it with your with the cardiologist, and they will give you a better idea. Yes.
My mitral valves don't close. What can I do? Or I mean, obviously, I was born with it and didn't know it until a few years ago. And
so you're talking about structure, right? So when it comes to structure or valves, there are two functions. They're either leaking or they're too tight.
They're leaking.
If you have leaky valve, then we categorize it mild, moderate, and severe. If you have mild leaky valve, the kind of surveillance we want is follow-up every 5 years, because it takes them years and years. If you have moderate leaky valve, we want to follow you every 2-3 years. If it's severe, depending on severity, it could be every 3 months or every 6 months.
I go every 6 months.
So then you probably at least moderate to severe.
Yeah.
That's what I'm assuming.
That's what you, okay.
But there's nothing you can do to prevent it.
Okay.
If you have high blood pressure, because if you have hypertension, you want to make sure it's controlled. It's that sheer force of blood going through that deteriorates it. So you want to make sure you're on, if you have blood pressure, you have to have it controlled.
I was at 195 over 110.
And you're still talking?
No, they had to bring it down. I was taking 6 blood pressure pills a day.
Yeah, you need a good cardiologist to follow you up. So keep up the good work with your cardiologist.
Thank you.
My pleasure.
When you put a stent in and it expands, and how does the cholesterol get rid of? How do you get rid of the cholesterol?
No, you squash it against the wall.
And it's absorbed then?
No, it just gets squashed. However, if you don't have your cholesterol under control, it gets rebuilt inside. New ones keeps getting built up. Plus, patients are on at least 2 blood thinner to keep the stent open for the first year. And then depending on whether you have another heart attack, depending on people behaving or not, then, yeah.
So it doesn't go away, it just stays solid against the wall.
Yeah, so there's soft plaque and there's hard plaque. Hard plaque is when there's a lot of calcium deposits. When people have a lot of calcium deposits, there are different, remember, medicine is an art. There are different catheter they use that it goes and kind of like chisels all the calciums out. It cleans it out, and you put the stent in. But remember, if you were diabetic, hypertensive, cholesterol, smoking, obesity, sedentary lifestyle, if you don't change anything, and this is what I tell my patients, if you change nothing, nothing will change. The miracle is not your doctor. The miracle is you doing the right thing. Be organized, all right? This is one of the things I want to really share with all of you. I know a lot of us could be on more than one medications. You're not expected to memorize, but be organized. Keep a list of your blood pressure, your medications. It's not your doctor's job to know what your medication taking. Do you know how many patients a doctor sees? Average 3,000 people. They're not going to memorize what you're on. It's your job, especially if you see more than one doctor. All right? You have to keep all your doctors who gave you what medication. So please, 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 if you get nothing out of this conversation, you have to be organized. Who are your doctors? Grab a card. What medications are you on? Because they have side effect, they have interaction. You have to always say, and also, I always give my patient a list of their medications. It doesn't matter what I have on my list. What matters is that what are you doing at home? So always be organized. You don't have to memorize your medications or list of meds. What other question? Yeah.
So when is the best time to check your blood pressure?
Excellent. Thank you for asking.
How often should you check?
Very good question. Very good. Thanks for bringing that up. So the right time to check your blood pressure is late in the morning, middle of the afternoon, or right before you go to bed. All right? Do not check your blood pressure when you just woke up, just ate, just had coffee. Don't check it when you just came from a walk or you're upset. Those are the times it's going to be up, all right? Do not check your blood pressure every day. At least that's not how I tell my patients, all right? If I want you to do every day, would be to dance, sing, pray, meditate. I don't care what your blood pressure is every day. It doesn't matter which arm you check it, although predominantly most people here left because my heart is on the left side, but honestly there should be no difference in the blood pressure check whether you do it arms or legs, all right? Up to 10 points difference, it's okay, but if it's more than 20 to 30 points difference, that's a red flag. And if I'm adjusting medications, I ask my patient to check it 2-3 times a week. Once we know what regimen works and we have it under control, then I ask them to check it 2-3 times a month. And if you forget, guess what? Who cares? You should be relaxed.
Thank you.
Anybody else? Yes.
If somebody had several of the risk factors, but they hadn't yet had a blockage or a heart attack, what would you tell people in general of all the things we can do to help ourselves, whether it's, watch our diet and have a more healthy diet, or exercise more, or like, you probably don't want to prioritize, but if you were to say, You're overwhelmed, so start with this. What would you tell people?
Eat healthy and exercise. And be happy. Stress is another indication of get rid of negative people in your life. Easier said than done, right? You can't choose your family, you can choose your friends. Right? You know, I just came from a trip to France. The only obese people I saw in France were Americans. One of the things is portion control. Any further question? No?
I have another one. Can you explain just a little bit more about that calcium score test?
Very good. Calcium score is recommended for people who are asymptomatic, meaning they don't have any symptoms. All right? And usually I recommend it to people who have risks for heart disease, like hypertension, high cholesterol, diabetes. But if somebody's having actual symptoms like chest pain, shortness of breath, fatigue, blah, 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 that's not for them. This is for asymptomatic with risk factors. And usually, somebody above age 40. And it's recommended and repeat every 5 years. It's not something you want to have every year. Now, what's the concept behind that? The coronary artery, the plumbing, what has been shown is that people start having calcium plaque along their vessels, around their pipes. So our calcium score should be 0. If your calcium score is above 100, you should be on cholesterol medicine. If your calcium score is above 400, you're definitely 100% have blocked arteries. And how we approach each score is different. We're done? Thank you so much, everybody. Thank you so much.
Thank you so much. It's amazing. Discussion, I learned so much. Thank you, everyone. Welcome. I'm Jonathan Robles. I'm here with the Community Alumni and Foundation Relations here at the college. So it's great to see all of you here and all of you colleagues and students. So we're close to Friday. This is Friday Eve, what I say. So, and knowing that the weekend is close, that's always good for my health. That's my heart. So I'm here to say some closing remarks on behalf of our president, Dr. Ray Videtta. Unfortunately, he wasn't going to be here today. He's traveling to a conference. So allow me a couple minutes to read his remarks. On behalf of our college president, Dr. Videtta, is also proud to serve on the Sun Health Foundation board. Thank you for attending today's very important discussion on heart health. At Estrella Mountain Community College, we're deeply committed to the well-being of both our students and employees. Our strategic goals do include employee and student well-being, and providing valuable opportunities like this to learn is a testament to our intentionality in meeting those goals. I know what I'm doing right now with these strategic goals for the college. I'm changing both lifestyle changes and health style for me to improve my wellness. So please, again, join me in thanking Dr. Sadeghinia. Whether you're actively managing risk factors or simply being proactive about your health, we hope you leave with a renewed sense of purpose and a clear path toward long-term cardiovascular wellness. Again, we're proud to host events like this, but especially partnering with Sun Health Foundation that empower our community to make informed decisions for a healthier future. So thank you again for being here, and I hope to see you at the West Valley Heart Walk. If you haven't seen this, we're going to have a team there at the college, so please pick up some flyers and participate. This is a great beginning to get your health in shape. Thank you. Thank you. It's a 1 month. Yeah, we'll be there. Thank you. Have a great rest of the day. Thank you very much.